speaker. Dr. Nadia Jabeen is working as a consultant pathologist at Vijaya Diagnostics, Nagar branch since a year. She has she was previously used to work at Vijaya Mary Hospital, Hyderabad, and was handling hematology, clinical pathology, and histopathology. Dr. Nadia Jabeen has graduated and did post-graduation pathology from the prestigious Osmania Medical College, Hyderabad. Now I welcome our speaker, and without further wasting our time, we'll hand over the session to Dr. Nadia. Dr. Nadia.
Thank you, sir, for the introduction. Good evening, everyone. Sorry for the delay. Today's topic of discussion is iron-resistant iron deficiency anemias. Today's topic of discussion is iron-resistant iron deficiency anemias, also known as iron-refractory anemias. Now, as our subcontinent is endemic in iron deficiency, with more than 2/3 of the children between 2 to 5 years of age affected by it, so these children are prescribed generally oral iron treatments by the clinicians, and they are checked for response to that oral iron treatment after a period of 2 to 4 weeks. Some cases do respond, whereas other cases which do not have a optimal response, or they have a suboptimal response or no response at all, generally tend to get neglected. And these people have the anemias persisting into the adolescence and the adulthood. So this is where we have to have a overview of iron-resistant iron deficiency anemias. So this is a relatively newer condition, which is an autosomal recessive disorder, and is generally misdiagnosed or underdiagnosed in children as well as adults because of lack of general awareness, and also because of lack of definite plan of approach to such cases. So I'll be discussing these topics under the following headings: introduction, a brief overview of the functions of iron, as well as what is the definitions of iron deficiencies, definition of anemia, what is microcytic hypochromic picture, followed by the role of hepcidin, its synthesis and regulation. Hepcidin here plays a key role in the iron refractory anemias because hepcidin regulates the iron homeostasis in the body. Followed by what are the genetics involved in iron-resistant iron deficiency anemia, then how do the patients clinically present, then how do we differentiate it, differential diagnosis, how do we differentiate it from other causes of microcytic hypochromic anemia, and then a brief overview of the treatment. Introduction, role of iron in body functions. So apart from just carrying oxygen to cells, iron is also involved in catalyzing various enzymatic reactions in the body, thereby playing a part in even DNA synthesis and cell proliferation. So any deficiency in iron will not only result in anemia, but will also hamper the neurophysiological development, especially in children and infants. So how do we define anemia, especially in kids? Because this presentation is going to be from the perspective of pediatric population. HB less than 11 in the age group of 6 months to 5 years, or less than 11.5 grams per deciliter in the age group of 5 to 12 years is defined as anemia. Whereas iron deficiency is considered when the ferritin levels are less than 12 micrograms per deciliter in the age group of 6 months to 5 years, and less than 15 micrograms per deciliter in the age group of 5 to 12 years. Now, iron deficiency is when you have the picture of anemia where the hemoglobin is lower than the said values, as well as the iron is lower than the values. So we get iron deficiency anemia in such cases. And a microcytic hypochromic picture, especially in the pediatric population and in iron-resistant iron deficiency anemias, we have an MCV less than 65. Normally less than 80 is classified in adults, but in IRIDAS we classify them as less than 65 for MCV, and MCH should be less than 20 picograms to be considered as microcytic hypochromic anemias. So where do we encounter iron deficiencies? Majority of the cases are acquired. The leading cause being nutritional. Then we have bleeding, any bleeding from the GI tract, the genitourinary tract, and also the gastrointestinal malabsorptions or Helicobacter pylori infections. And the malabsorption, we might have celiac sprue, achlorhydria, which inhibits iron absorption in the GI tract. Then any cause of chronic inflammations will lead to iron deficiency anemias. Then we have the hereditary causes. And this is more important for the topic per se. So where do we encounter hereditary conditions? So the defect is in iron uptake in the body, defect of iron absorption. So this is the factor, this is the place where the iron resistant iron deficiency anemia arises. So it is difficult for the iron to get absorbed to the duodenal enterocytes because of deficiencies of certain proteins, which I will be discussing later. Among hereditary, apart from iron absorption, we also have defects of iron transport or uptake. Like the transference is a protein transporter for iron in the plasma. So any low levels of transferrin due to a genetic disorder like hypertransferinemias will have defects of iron transport and uptake. Then we can have defects in iron recycling and defects of erythroid mitochondrial iron utilization, where we generally see mutations in DMT1 and STEP3. Coming to hepcidin. Now, hepcidin is the major important regulatory hormone for iron hemostasis. So, because iron is absorbed from the enterocytes, but there is no definite excretory pathways for iron. So, the negative regulation of iron is generally done by the hepcidin. So, it's important to understand the pathogenesis of the iron resistant iron deficiency anemias with respect to hepcidin. How is it upregulated? How is it downregulated in the normal body? So hepcidin is encoded by the HAMP gene, which is a peptide hormone synthesized by hepatocytes. And how does it block the entry into the, how does it play a role in blocking the entry of iron into the body? So I'm showing a schematic representation. We have the hepatocytes, which release the hepcidin. And this hepcidin acts on the macrophages, which are the storage forms of iron released from senescent erythrocytes. Hepcidin again acts on hepatocytes and also acts on the enterocytes. So at all these channels, we have ferroportin receptors, which helps in transport of ferritin either from the GI tract to the intestine or from the macrophage to the exterior into the plasma. So these ferroportin channels are acted upon by hepcidin, which gets degraded, internalization of the ferroportin into the cell occurs and it causes degradation of ferroportin. So hence the iron which is trapped in the macrophages and hepatocytes as stored iron cannot be released into the plasma, whereas the iron present in the GI tract cannot be absorbed into the circulation. So this leads to a low level of transferrin saturation into the body. So how is hepcidin synthesis upregulated and downregulated? So hepcidin is generally upregulated when there is increased iron in the body. So the reverse holds true, like the reduced in any forms of iron deficiency, the hepcidin is downregulated because once the hepcidin is increased, iron absorption can be inhibited. So iron, bone morphogenetic protein signaling. These are the major proteins which upregulate hepcidin, which includes hemojuvelin, BMP6 and SMAD. So these are the pathways which are involved in hepcidin synthesis. Inflammation. Any sort of inflammation in the body can elevate the levels of hepcidin because hepcidin is an inflammatory marker. And what factors downregulate the hepcidin? The factors which reduce hepcidin levels in the body are increased erythropoietic demand. Any demand where the synthesis of RBCs needs to be increased, hepcidin is downregulated. Then hypoxia, again effect of anemia, which anemia and low iron deficiency, iron deficiencies can lead to hypoxias, which reduces the hepcidin synthesis. And then endocrine regulation, estrogen, testosterone, or growth factors can also reduce the hepcidin synthesis. So how does hepcidin synthesis actually occurs in the body? So we have a serum iron and transferrin saturation complex. This complex, if it is the transferrin saturation is optimal in the body, this complex is detected by HFE, TFR2, and hemojuvelin iron sensing complex. This trio proteins form an iron sensing complex which detects the transferrin saturation. If the transferrin saturations in the body are high, implying that the iron levels are adequate or optimal, then the hepcidin levels increase, thereby blocking the level of iron entry from the enterocytes or its release from the macrophages. So understanding this iron sensing complex is important to understand the pathway of hepcidin synthesis. So this is a schematic presentation of how the iron sensing complex detects the iron levels and transferrin saturation in the body and then plays a role in the synthesis of hepcidin. We have the transferrin receptor 1 which binds to the HFE. So once the levels of transferrin saturations increase in the body, this HFE is displaced from TFR1, transferrin receptor 1, and goes and binds to TFR2, transferrin receptor 2. This activates the hemojuvelin protein. The hemojuvelin and the bone morphogenetic protein are co-receptors. So these co-receptors activate the bone morphogenetic protein receptors in the SMAD signaling pathway. So these are the proteins which are present in the signaling pathway of hepcidin synthesis. So hemojuvelin and bone morphogenetic protein combination causes the phosphorylation of certain proteins in the pathway, causing synthesis of hepcidin. It is also important to understand here that there is a transmembrane protein called matriptase 2, which cleaves this hemojuvelin and downregulates the production of hepcidin. How is it important? We'll be discussing in the later sessions. So matriptase 2, as already said, interacts with hemojuvelin and causes the hemojuvelin fragmentation. So how does hepcidin plays a role in different types of anemia? Under optimal conditions in normal hepcidin levels, we have normal plasma iron levels. But when it is anemia of chronic disease we generally have elevated inflammatory markers, hence even hepcidin is elevated. So increased hepcidin production in anemia of chronic disease will inhibit the absorption of iron from the enterocytes, leading to lower plasma iron levels. So this is how in anemia of chronic disease, hepcidin plays a role. Whereas in hemochromatosis or iron overload, we have low hepcidin expression. So this causes uninhibited iron absorption from the enterocytes, leading to overloaded plasma iron. So we see how the hepcidin and iron are inversely related to each other. If the iron levels in the body go up, hepcidin levels go down. So in hereditary hemochromatosis and iron loading anemias, we have reduced hepcidin levels, thereby elevating the iron levels in the plasma. Whereas in anemia of chronic disease or anemia of inflammation, iron refractory iron deficiency anemias, and hepcidin secreting tumors, we have elevated hepcidin levels, thereby reducing the iron levels in the plasma. So this is the normal homeostasis maintained when we have optimal level of both iron and hepcidin. So what are the genetics involved in iron-resistant iron deficiency anemias? So iron refractory or iron-resistant anemias is a group of hereditary disorders, which is a recessive condition due to a defect in the TMPRSS6 gene. For convenience, let's say it as TMPRSS6 gene encoding the matriptase 2. So as I already said, the matriptase 2 causes fragmentation of hemojuvelin. So it plays an important role in hepcidin regulation. So hepcidin is downregulated by matriptase 2, and it is this matriptase 2 which is degraded in iron-resistant iron deficiency anemia, which causes uninhibited production of hepcidin in the body. The TMPRSS6 gene is located on chromosome 22, and it encodes this matriptase transmembrane serine protein. It plays an essential role in downregulating hepcidin by cleaving the hemojuvelin. And even matriptase 2 is expressed on hepatocytes the way hepcidin is. So this is the structural form of the matriptase 2, which we have the serine protease domain in the blue color, and the rest of the part is the non-serine protease domain. So major forms of the mutations occur in the serine protease domain, and this form of mutations generally give rise to more severe forms of anemias. This is the catalytic domain, which is more important in the structure of the matriptase 2. So we can have 40 different mutations in the TMPRSS6 gene, which can be missense, frameshift, intronic, nonsense. And these mutations can be spread throughout the gene sequence of this TMPRSS6 gene. So the mutation needs to involve both the alleles, either as homozygous mutation or a compound heterozygous mutation, to qualify for a confirmed diagnosis of iron refractory anemias. Since it is an autosomal recessive condition, both the alleles need to be involved, and the involvement can be either homozygous or heterozygous. And depending on the type of mutation, whether it is homozygous or heterozygous, the clinical phenotypes will be varying. How does iron-resistant iron deficiency anemias present? They are generally diagnosed or present during childhood because most of the pediatric population are iron deficient, and they present with mild to moderate anemias, and their growth and development are normal. So we have variable degree of microcytic hypochromic indices depending on the type of mutations present in the TMPRSS6 gene. And then we have low normal to normal serum ferritin levels, very low serum iron and transferrin saturation. Low normal to normal serum ferritin levels is a little different feature from iron deficiency anemias, because we generally have very low serum ferritin levels in iron deficiency, whereas in iron refractory we have low normal to normal serum ferritin levels. Very low serum iron and transferrin saturation, which is it's similar to what is seen in iron deficiency anemias. Then we have the important part, inappropriately high levels of serum hepcidin compared to the degree of anemia. Because once you have iron deficiency and iron deficiency anemia, hepcidin physiologically should be downregulated. But in iron refractory anemias, we have high hepcidin levels in the body. Then oral iron refractoriness as per standard criteria for evaluation of response to oral iron. So what is oral iron refractoriness? We have a less than 1 gram per deciliter raise in hemoglobin after 4 weeks of oral iron therapy. So a suboptimal response or no response at all to oral iron is considered as oral iron refractoriness. Then presence of homozygous or compound mutations in the TMPRSS6 gene. This is the final step where we do the genetic analysis of the TMPRSS6 gene. So how do we differentiate it from other different forms of anemias? As I've already said, iron deficiency anemias are supposed to have decreased levels of serum ferritin, whereas in iron refractory, we have either normal or no normal. Then we'll have to differentiate it from thalassemia, which is a hereditary cause of microcytic hypochromic anemia, wherein we will have elevated RBC and retic count. And the transferrin saturations, the total iron binding capacities, the serum iron levels are all normal. It's only the microcytic hypochromic picture which have to be differentiated. And then we have anemia of chronic disease. This is one condition where the serum hepcidin levels are elevated as well, but the serum ferritin is normal to increase, in contrast to iron deficiency anemias where the serum ferritin levels are decreased, and even in iron refractory we have low normal to normal levels, but they are never increased. So how do we differentiate it from iron deficiency anemias or any other cause of microcytic hypochromic anemias? First is the onset. Onset is mild to moderate degree of anemias in infancy or early childhood. Then we have a history of anemia in other siblings or an elder sibling being chronically treated by iron deficiency without much improvement. Iron refractory anemias were actually described or spoken about in detail from in the 1980s by a certain group of scientists, and they were first diagnosed in siblings only. And over the years also they have been diagnosed or documented in siblings. So this is an important part of the history. An uncorrected anemia despite oral iron treatment in the siblings. Microcytosis and hypochromia extreme compared to the degree of anemia. Very low MCV and very low MCH, which is not correlating with the degree of hemoglobin levels. Then we have absence of organomegaly and absence of minimally evident stigmata of classical iron deficiency. Absence of organomegaly generally rule out thalassemias or any other hereditary causes of anemia in the infancy or adolescence. Then we have very low appearance of symptoms of iron deficiency like hair changes, dry skin, chylomicronemia, and angular cheilitis, which is generally seen in classical iron deficiency but not seen in iron refractory anemias. And then the important aspect is high RBC count and low retic count. We have a high RBC and low retic in iron refractory anemias, whereas in uncorrected iron deficiency anemias, we have low RBC count and low retic count. And then in thalassemias, we have a high RBC count, but the retic count will be lower. This is a flowchart representation of how do we go about cases of microcytic hypochromic anemias. So once we get a case of a microcytic hypochromic picture in a child less than 12 years of age, we should evaluate them with a peripheral smear. And if the peripheral smear is showing nucleated RBCs and target cells, then a family history of hemoglobinopathy should be sought. And if there is a history or if there is not a history and we have target cells and NRBCs, then it's better to go for a HPLC to check for any hemoglobinopathies. But if the patient is showing a concomitant iron deficiency symptoms as well as the picture is showing a microcytic hypochromia along with elliptocytes, then it's better to get the serum ferritin levels evaluated and treat the patient for iron deficiency before they undergo the HPLC procedure. And then once we rule out the hereditary causes of microcytic hypochromic picture, we should see for any joint pains or fever in the patient to rule out any chronic inflammation. If the ESR and CRP is elevated, then the patient is most likely suffering from anemia of chronic disease. Then if there is no obvious cause of anemia on general physical examination, we don't have any target cells in the peripheral smear, the patient doesn't have any chronic inflammation or any inflammatory markers in the body, then we are supposed to give a oral iron challenge test, wherein we give 3 mg per kg of oral iron in divided doses and look for response. If there is a response of more than 1 gram per deciliter at 3 to 4 weeks of iron treatment, then it confirms iron deficiency. And we should continue the treatment for 3 to 4 months until the hemoglobin is normalized. But in cases of suboptimal response or no response at all at 4 weeks of age, diagnosis of oral iron refractoriness is to be made. So once we have the diagnosis of oral iron refractoriness, we need to investigate is the cause acquired or it is a genetic or hereditary. So first we need to advise a complete iron profile where we check for serum iron levels, ferritin, transferrin saturation and total iron binding capacity. Plus certain more investigations to rule out acquired causes of GI tract pathology, celiac disease, H. pylori infection, autoimmune gastritis. All these are the causes of reduced iron absorption from the GI tract. So the acquired causes along with the iron profile should be tested. And if we have this, the profile of typical iron deficiency, like low ferritin levels, low transferrin saturation levels, and high total iron binding capacity, then a prolonged oral iron treatment should be given. Or change iron formulations and see the response. Because there might be a compliance issue or there might be underdosing of the iron formulations. So it's better to prolong the treatment and change the iron formulations and check for the response. If the patient is responding after changing the formulation, then yeah, we have a classical iron deficiency. But if the patient is not responding to a change of iron treatment, or then with typical iron profile, the iron deficiency profile, we have an unexplained refractory iron deficiency anemias. But if the iron profile is atypical, like we have very low iron and transferrin saturation, but the ferritin levels are normal to low normal. There is an iron deficiency, we have low ferritins. Here we have low normal to normal ferritins. Then we should evaluate the patient for serum hepcidins or urine hepcidin levels. So the hepcidin levels can be detected either by immunoassays or mass spectroscopies. And then if we find that there are inappropriately high levels for the degree of anemia, then we should do a hepcidin TSAT ratio. Hepcidin levels are elevated and transferrin saturation is reduced in iron refractory anemias. So if we have a high hepcidin and transferrin saturation ratio, then this is a very sensitive marker for iron refractory anemias. The patient should be evaluated and should undergo a genetic analysis and sequencing of the TMPRSS6 gene. But before doing all this, we should a thorough history taking is very important to check if the patient has been compliant or not, or is the patient irregular with the treatment. So as I already said previously, that if the patient has not been compliant or if the patient has been underdosed, we need to change the formulations and prolong the treatment by more 6 to 8 weeks to check for iron response before proceeding for the genetic analysis due to the cost. Now, among the iron profile, if we have high serum iron and high ferritin levels, then we should be ruling out hypotransferinemias or atransferinemias, sideroblastic anemias by examining the bone marrow to check for ring sideroblast. And if all of these are ruled out, sideroblastic anemias, transferenemias, then a rare form of mutations like STEP3 and DMT1 should be checked. So what is the treatment of iron refractory anemias? Because there is oral iron refractoriness in iron refractory, treatment is largely based upon IV parenteral iron administration. But according to the current recommendations and guidelines, it is always good to go for a ferrous sulfate form along with vitamin C for at least 6 to 8 weeks before going ahead with the IV iron treatment. So patients, depending on the type of mutation, whether they are homozygous or heterozygous, will respond variably to the iron treatment. There are cases which can respond, there can be cases which can respond to oral iron treatment for a prolonged duration. And there might be cases which might not show any response at all. So for such cases, it's better to administer the IV iron. So takeaway points from this presentation. Iron-resistant iron deficiency anemias has overlapping hematological features with classical iron deficiency. So it's always better to have a diagnosis of iron refractoriness in the hindsight when we are approaching cases with microcytic hypochromic picture, as well as low serum iron and transferrin saturation, especially if the patient is not responding to oral iron treatment. So for that, a thorough history taking to rule out compliance issues and a testing for ruling out the acquired causes of iron deficiency anemias. To rule out the celiac disease, H. pylori infection, celiac sprue. So it's better to always have a thorough history taking before proceeding with the further investigations. Hepcidin plays a major role in the diagnosis of iron refractory anemia. It is a very promising tool which can be added to the battery of investigations in diagnosing iron deficiency status. But because there are no international standardized practices followed and there are no controls available, we need for full inclusion in the public health, it requires further harmonization of the assays. Then hepcidin and TSAT ratio is a very sensitive marker to detect iron-resistant phenotypes uh, before they are subjected to the gene analysis. So because the mutations are heterozygous, they can involve the introns as well as the exon-intron boundaries. We have to sequence the entire gene, TMPRSS6, through genetic analysis. And then the treatment is already said with oral iron and along with an inclusion of vitamin C for 6 to 8 weeks, followed by parenteral iron if there is no response or minimal response. And then lastly, siblings should always be screened because as it is an autosomal recessive disorder, it can be more likely present in the siblings as well. So they should be screened with a complete blood picture, including the peripheral smear examination to detect the presence of anemia. And if present, and if there is a history of oral iron refractoriness in them as well, they should be offered targeted mutation sequencing. Thank you.
Thank you, Dr. Nadia. It was a very wonderful and insightful presentation on the important diagnosis of hypotonic neurotic anemia. Now, if any queries are there from the audience, we'll take up in this session. Uh, Please type in the chat box for any queries. There is a query. Dr. Nadia, can you please elaborate the role of hepcidin in anemia of chronic diseases versus iron refractory iron deficiency anemia?
In any, as anemia of chronic disease and iron refractory anemia both have elevated levels of hepcidin. So it's a little tricky to differentiate between the two conditions. Because iron deficiency anemias have prolonged the iron absorption deficiency from the GI tract, iron refractory anemias, we don't have any stored levels of iron in the body. Whereas in anemia of chronic disease, they generally arise after a period of chronic inflammation. So we do have stored iron in the body, but that iron cannot be utilized for iron RBC synthesis. So the way we differentiate is we have low normal to normal serum ferritin levels in iron deficiency, iron refractory anemia, but anemia of chronic diseases will have elevated serum ferritin levels. And also the inflammatory markers will be elevated in anemia of chronic disease, whereas we don't see that in iron refractory anemias. But the serum ferritin which needs to be differentiated between the two.
There's another query. Is there any role of bone marrow in investigation, bone marrow examination, since it is an invasive in a testing process? So, will it be helpful for this condition?
Yeah, in iron deficiency anemias, the picture will be iron refractory anemia. The picture will be similar to what is there in iron deficiency anemias. We'll have reduced iron stores on Russian blue staining on the bone marrow examination. So again, it is the hepcidin levels and the genetic analysis which will play a diagnostic role and not the bone marrow. We can just diagnose that as an iron deficient state.
Thank you, Dr. Nadia. If there are any more questions, please type in the chat box. We'll wait for 1 minute. I think there are no more queries. You can wind up the session. Before winding up the session, I want to thank the management for giving us this opportunity, Vijaya Diagnostics Limited. And I thank the supporting staff, IT team, and digital marketing team for their support. And finally, all the audiences for their active participation. And Dr. Nadia, it was a very wonderful and insightful presentation. Thank you.